today, and I'm hoping that the next 3 days is going to be full of very fruitful interactions in a warm and conducive environment. I'm particularly happy that we have such support from the government and that the Health Secretary, the Director of the Institute of Mental Health, the President-elect of the IPS and the Minister could join us. It obviously indicates the state is actively engaged in activities of the non-governmental sector, particularly in the mental health field. What I'm supposed to do today is to speak to you about the clients and the caregivers' perspective. Now, I'm doing it on behalf of the Banyan, but I will also certainly bring in a bit of my experience. So here again, like Dr. Pungode, I play 2 or 3 roles. One is that I have, both Vaishnavi and I have been engaged with the Banyan over the past 17 years. So that's as a caregiver, as an administrator. 2 is as a friend of very many people who've been at the Banyan. I obviously have shared a lot of experiences with them. And 3 is as a user survivor myself. I obviously have a bit of an insight into the issue. So I think there are 3 different roles that I play here today. So most of you relate the Banyan to an institutionalized setup, but I would like to just quickly run you through some of the figures. So we are a transit care center that operated since 1993, and to date we've reached out to 1578 individuals who have been homeless, who've been rescued by the Banyan. We've reintegrated, which means they've gone back home, 900 of them, and we've interacted with their families. The urban mental health program, which began in 2002, has reached out to about 750 people. The daycare has reached out to 60 people, 30 of whom have been employed. The DA group, which provides access to social entitlements, has reached out to about 250 people across 3 different project sites. That's the city, people who have been at Adekalam, that's the center that reaches out to homeless people with mental health issues. And the third is a rural setup, which is Kovalam. Long-term clients, that is individuals who don't have an opportunity to go back home but who are doing fairly well and require just a little bit of supervision and can live in a non-restrictive environment is 60. And those from that group who formed a self-help group, or rather 2 self-help groups, are 32. So I speak on behalf of these large numbers and not just the impression that usually people have of the Banyan being an institutionalized setup and having only 200 people in an institution. We've actually interacted with about 5,000, 6,000 people from primarily the low socioeconomic groups. Now that's another reason that I'm very happy that we have a mix in terms of different people from different socioeconomic groups today. I think that's extremely critical because usually those who advocate are urbane English-speaking individuals, but it's important that the needs of people from the low socioeconomic groups, pain is universal, but I think it's very critical that the needs of people in the low socioeconomic groups are reflected when we talk policy, when we talk legislation, when we talk services. And I'm glad that we have a good representation of our clients and our caregivers here today. And some of their views is what I'm communicating. We have a group of translators who will translate for the benefit of our clients. And I stand here on behalf of them primarily. Now, this is a map that, Naveen, could you just mention toward approximation that?
Okay, this is a geographical spread of almost 850 patients of Banyan at Adekalam, and using open source free software from Google and other apps, we have just mapped out the location, population density of people from all parts of India. There are a few from Sri Lanka and 1 from Nepal also. The main takeaway point from this map is it's geographically spread all over the place. The people at Banyan come from all over, and it is as accurate to the district level for small cities, and for bigger cities, since the addresses we collated were reasonable, we can go to the street level or to a given landmark. So
now this I did primarily because I'm not tech savvy, so it just excited me to see several red dots and blue dots on the map. But I think this is a clear indication that people who have wandered away from their homes are not only from Tamil Nadu. While the largest concentration of persons are from Tamil Nadu, but people all the way from Nepal, from Gujarat, from Delhi, from Bihar, from Orissa, from Maharashtra, from Madhya Pradesh and Uttar Pradesh have come to the Banyan. The greatest number of people being from Andhra Pradesh and the least number of people being from Kerala. Several people from Karnataka as well, despite the presence of an organization like NIMHANS and various other facilities. So this obviously indicates that lack of access is a huge issue that we have to contend with. So this is not so much to boast of the numbers in the spread that we have reached out to, but to indicate that so many people have gone without any sort of a service and ended up absolutely homeless and alone on the streets. So now, since I have spoken about poverty and the sorts of people that we reach out to, I think it's important to correlate poverty, the place of stay, and higher disease and family burden. So all of us are aware that the Tendulkar Commission has clearly indicated that about 40% of our population belong to below poverty line families. So essentially what internationally is classified as being below the poverty line is if you earn less than $1 a day. And about 40% of that in India, 40% of people fall under that category, and 80% of people fall under below $2 a day category. So obviously abject poverty is a huge issue that most of India, people with mental health issues or otherwise, have to contend with. And what does that mean? Now further what complicates the issue is the divide between rural and urban spaces. So we have about 72.2% of our population located in rural areas. Now, most of the facilities that are lacking, or most of the, as you are probably aware, homelessness is an urban phenomenon. So all the people whom we find here in Chennai are not from Chennai per se, but they're from rural areas where they've tried to access facilities, found no support, and then ended up homeless. And not ended up homeless because they've always been abandoned. Sometimes he has been abandoned, but several times they've wandered away for want of facilities. So the 72.2% of the rural people obviously face a huge problem in terms of just the distance that they have to commute to find a basic facility. And then is the issue of the urban poor. Now the issue that the urban poor faces is very different. They face issues of stigma and of housing. We, for example, had a resident who's moved 200 times, and I'm not joking, 200 times in 1 year, simply because of the stigma that they faced because their neighbors weren't willing to accommodate the differences of a person with a mental health issue. And this is just one case. I pick on individual persons, but this is reflective of the larger pattern. Family size is huge, and the reality is that when you are in a family, the breadwinner of the family is constantly trying to accommodate the needs of various people. So it can get very distressing if there is a person with a mental health issue, because it is a reality that the person is trying to balance out the needs of a person who's supposedly productive versus a person whom she cares for as deeply, but she's not in a position to do too much. And if she has to compromise and make sure that a particular person sort of takes the whole family forward, then she's somehow, sometimes inclined or tempted to focus on that other person. Not that the love for this person is any lesser, but just that circumstances result in a reality such as this. And it is truly sad. This ought not to be the case, but this is not a situation that many of us will understand appropriately unless we are in that situation. Out-of-pocket expenditure is, of course, something all of us talk about. This is probably the single largest burden, because several of the people who access facilities, even from the poorer socioeconomic groups, when they are not able to access a localized facility, travel to the nearest private psychiatric clinic or government clinic, and there is expenditure on travel, on loss of wages, and on various other aspects. Now this is just a sample again, just to indicate that many of the people, here it's a sample of reintegrated clients, are about a large percentage, as you see, are below the 5,000 rupee category, a smaller percentage below the 10,000, and all the other amounts are negligible. The primary reason I have this is to indicate the kind of caregivers. So it's not just, we have different sample groups, and each sample group varies because there are different kinds of carers. The poverty levels, of course, remain the same. But here you see that a large number of people are sons, so they're younger, are sisters, are daughters. Then you have our brothers, then you have a group of people who are mothers, then you have a group of people who are husbands, and then you have NGOs. So the caregiver is not always the mother or the father or the husband or the wife. It's several times a child, and that has, it's sometimes an extended family, it's sometimes an NGO, it's sometimes an extended relative. So it has different, so this obviously brings in all sorts of perspectives, because this whole process of caregiving itself is extremely dynamic in nature. Now, mental health care load, everybody has been talking about this. So the numbers are there to see. Major mental disorders in India, minor mental disorders. And as far as the Banyan goes, a large number of people are people who are affected with psychosis and schizophrenia in particular.